So good afternoon. I am pleased to present the grand round, to moderate the grand round, and I am most than honored to present our speaker, Dr. Hamad Al-Subaie. Dr. Hamad Al-Subaie is well known with the Kekas family, and he did medical college in Kitsai University. He finished in 2014. Then he applied for the residency in ophthalmology and the fellowship in surgical retina cases, and he just graduated this year in 2021. And among his achievement, he's a chief fellow of the fellows for the last year, and also he was the best resident in 2 years during residency. And for me personally, I'm really happy because I think he's one of the brightest minds I have ever the chance to be able to work on. Okay, so the floor is yours for you, Hamad Al-Subaie. I'm sure you will delight us with your lecture.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me?
Perfect.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Robio, for your kind introduction. It's my pleasure to present in this grand round today. So today I will present this topic, which is characteristic OCT finding to know. So I thought about many topics to present. Then I decided to present this topic, and I bring all the cases that I saw during my fellowship. That these cases has an OCT finding, and these OCT findings are characteristic for some diseases and some pathology. And these findings will help us, inshallah, in diagnosing, managing, and counseling our patients. Just a reminder, it is not, these signs is not pathognomic for some diseases, but it is characteristic for some disease or pathology. And this grand round lecture, inshallah, will be case-based talk, and inshallah, it will be very beneficial for all. So before we start in the cases, just 2 slides about the OCT. What is the optical coherence tomography? It's an imaging technique with high resolution cross-sectional image. It is around 3 to 15 micron. It is analog to ultrasound, but instead of using sound, instead using light. And due to the light conduction property of the eye, it makes it specially suited for OCT imaging. And this is the normal OCT. Just a reminder, this is, as you can see, this is the posterior cortical vitreous. And the first layer is the nerve fiber layer. Then we have the ganglion cell layer, which is the hyperreflective here. Then the inner plexiform layer. Then the inner nuclear layer, which they represent the inner retina. Then we have the outer plexiform in this hyperreflective layer here. Then we have the outer nuclear layer. And we can see there is a first hyperreflective line. This is the external limiting membrane. Then we have under it is the ellipsoid zone, which is the inner segment, outer segment junction. Then we have this most hyperreflective band, which is the RBE Brox complex, and we have under it the chora capillaris. This is just an introduction about the OCT. And now we will talk about the cases one by one. And we after the finish of each case, we will have message to deliver for the audience. This is the first case. This is a 55-year-old complaining of new onset flutters in the left eye for 2 days. His visual acuity is 20/20 in the right eye and 20/30 on the left eye. Clinically, he doesn't have a flat retina and he doesn't have a vitreous hemorrhage. And this is his OCT. As you can see, this OCT, there is epiretinal membrane, as you can see, and there is pseudo hole. But are there any more signs in this OCT? Yes. As you can notice, there is white deposits on the vitreous cavity. This is what we call it posterior vitreous opacity. Is this deposit can help us in managing our patient? Yes. This is one study published in 2020 titled OCT Assistance in Identifying Retinal Break in Symptomatic Posterior Vitreous Detachment. They collected all the patients that presented to ER with acute symptomatic BVD. And they reviewed their OCT and they checked which patient had a retinal break after. And they conclude in this study, if the patient has acute symptomatic BVD, and there is +3 posterior vitreous opacity on OCT, just like our patient, and there is no vitreous hemorrhage clinically, this patient has a chance 9 out of 10 to have retinal break with sensitivity and specificity more than 80%. So as everyone knows that if the patient presented to you with acute symptomatic BVD and there is vitreous hemorrhage, the risk is of break high. But if there is no vitreous hemorrhage and you have OCT and you found this vitreous opacity and it's more than 3, this patient has a 9 out of 10 chance of retinal break. So you need to go back and to check the periphery and do depression to rule out the break. And this is the message from the first case. This is the second case. This is a 23-year-old female with visual acuity in the right eye is 20/20 and the left eye 20/80. And he's complaining of the decrease in vision on the left eye for 1 week. And you can see this is the fundus spot of both eyes. It looks like normal. And we did OCT for our patient. And this is the OCT in the above for the right eye. You can see it's normal OCT, normal macular thickening and foveal contour. But in the left eye, you can see here, this is the ellipsoid zone, and there's a discontinuation of the ellipsoid zone. This is what we call it focal ellipsoid loss. And some people, they call it outer retinal cavitation. If you have such case with this OCT finding, the differential diagnosis is limited. And you have to ask about history to differentiate between this limited differential diagnosis. And the differential diagnosis of the focal ellipsoid loss is first, the photic maculopathy, which include solar maculopathy and laser maculopathy. So you need to ask the patient about exposure to laser or sun gaze. And the second diagnosis is the medication toxicity like tamoxifen. And this diagnosis also can be ruled out by history. And the third diagnosis is the macular dystrophy, like achromatopsia. And also this one can be ruled in or out by history by asking about the family history of the patient. And the fourth diagnosis is multiple evanescent white dot syndrome. So if you have patient with focal ellipsoid loss, you have to remember these differential, and you have to dig in history to differentiate between them. So our patient has a solar maculopathy, and this is one study titled Solar Maculopathy Prognosis Over 1 Year Follow-up. And in this study, they have 10 eyes of 6 patients with foveal damage from the solar retinopathy. In all 10 eyes, it showed focal ellipsoid loss in spectral domain OCT. And they conclude in this study that OCT offers a definite diagnosis for solar retinopathy, but you have to ask in history. And in this study, they showed the progression of this ellipsoid zone over months. And you can see in the left upper photo, after 1 week, you can see there is hyperreflective vertical line with focal ellipsoid loss. And after 1 month, you can see the focal ellipsoid loss is more clear. And after 6 months, there is partial healing of the ellipsoid zone. And after 1 year, it's the ellipsoid zone almost healed, but still there is a discontinuation. This is another study, which is stress and the result of the previous study. And they conclude that spectral domain OCT can be used to diagnose solar maculopathy. But they say similar OCT finding can be caused by the focal ellipsoid loss can be caused by other diagnoses, just like what we described in the previous slide. So you need to ask in history to differentiate between them. So remember focal ellipsoid loss, and remember these differential diagnoses, and you have to ask about history. We finish now the second case. We will go to the third case, which will take a long time. This is a 55 years old male. His visual acuity is in the right eye 20/80 and in the left eye 20/50. Referred to us for surgical intervention. If you can see his fundus exam, he's showing epiretinal membrane on both eyes. And you can see, and this is his OCT in the right eye, and this is his OCT in the left eye. And if you see this photo, you will say this is lamellar macular hole, which I agree on. But the question is not this. The question, are they the same? Is the patient in the lamellar macular hole in the right eye similar to the lamellar macular hole in the left eye? And we will answer this question in the next slides. Before we to answer our question, this is the definition of lamellar macular hole according to the International Classification Group. To have lamellar macular hole, the OCT should contain first a regular foveal contour, and second, defect in the inner fovea with or without tissue loss. And the third one, the split between the outer plexiform layer and the outer nuclear layer. And the fourth one is intact photoreceptor. Intact photoreceptor doesn't mean that the photoreceptor is not disrupted, but it means there is no discontinuation of the photoreceptor. Because if there is discontinuation of photoreceptor, we might consider it full thickness macular hole. So to go back to our question, this is one article titled Lamellar Macular Hole, Two Distinct Clinical Entities. And they divided the lamellar macular hole into two types. The first type is the tractional lamellar macular hole, and the second type is the degenerative lamellar macular hole. And our patient has both types and has the traction in the left eye and degenerative in the left eye. And the difference between these types, that the tractional has schitic appearance, as you can see in the photo, but the degenerative type has a cavitated appearance. And also tractional lamellar macular hole has epiretinal membrane, as you can see in this photo. And this epiretinal membrane is a thin and hyper-reflective line on the inner surface of the retina. But the degenerative type has more than 90%, they have epiretinal proliferation. And this epiretinal proliferation is the thicker pre-retinal of homogeneous reflectivity. So there is difference between these lamellar macular hole, which we'll see in the next slides. And they, to explain it more, the tractional, it looks like a mustache appearance. And the degenerative type, it looks like a top hat appearance. So just remember this photo, then you will, you know the difference between them. So and now we will talk about the second type. So everybody knows about the lamellar hole, the tractional lamellar hole. Now we will talk about the lamellar hole with epiretinal proliferation, which is the degenerative type of lamellar hole. It's usually have a poorer vision compared with the tractional type, and the diameter of the hole at the eye limb level and the middle layer is wider compared to the other type. And there is high prevalence of ellipsoid disruption compared with the tractional lamellar macular hole. And usually the retinal thickness at the base of the lamellar macular hole is thinner compared to the other type, because there is the retinal tissue loss in this type of lamellar hole. And usually this lamellar hole lacks cysts and lacks schisis. It is only cavitation. And the traction is not the force that lead to this lamellar hole. The force that lead to this lamellar hole is degeneration, not retraction. So is epiretinal proliferation just a lamellar hole disease as we saw in our patients? No. Lamellar hole disease can present in, epiretinal proliferation can present in the lamellar hole, but also can present in the full thickness macular hole disease, and also can present in simple epiretinal membrane. So it is not just a lamellar hole disease. So epiretinal proliferation, it is a thick, dense, homogeneous, multi-layered material of internal intermediate reflectivity and the external band of high reflectivity that conform to the epiretinal surface at the margin of the hole defect. And in the histology, it is a predominance of a glial cell with a specific molar cell. And the primary goal for surgery in patients with epiretinal proliferation, either with lamellar hole or with full thickness macular hole, is to avoid further foveal damage and stabilize visual acuity. Because as we said, that there is a high prevalence of ellipsoid disruption. So if we have patients with progressive ellipsoid disruption, this is the indication for the surgery. This is one study by Co et al. In 2017. They have 73 patients with the lamellar hole. 15 of them, they had lamellar hole with epiretinal proliferation. And the final best corrected visual acuity in eyes with lamellar hole epiretinal proliferation showed no visual benefit after surgery, despite anatomical improvement. And the reason behind that, because the ellipsoid zone did not recover. And in their study, the tractional epiretinal tractional lamellar hole usually improved in visual wise after the surgery. So for the surgical retina specialist, that you should know that the retinal proliferation has technically challenging during removal of the membrane intraoperatively. So in compared with the tractional retinal membrane. So intraoperative, this retinal proliferation appears to be yellow, and it is fluffy and more difficult to grasp and remove. And some author, they engage to remove the retinal membrane at the periphery and brush the tissue toward the fovea. And the reason behind that, to avoid inducing a iatrogenic full thickness macular hole, because the retinal proliferation is more adherent to the retinal tissue compared with the tractional retinal membrane. And also the retinal thickness is thin compared with the other types. So also some author engage iLim removal in location where there is no retinal membrane. So you might take the retinal membrane with the iLim during removal. And again, ensure care when peeling near to the fovea to avoid full thickness macular hole. So at the end of this case, in any case with lamellar hole or full thickness macular hole, you need to rule out retinal proliferation. And if retinal proliferation is present, you need to discuss with the patient that the vision might not improve in most of the cases, and the indication for the surgery to prevent the ellipsoid zone disruption and prevent worsening. And you have to be aware about the challenges during the surgery, because it's more difficult compared with the other types. Now, this is the fourth case. This is 14-year-old female complaining of decreased vision for 1 week in both eyes. The visual acuity is 20/60 in the right eye, 20/200 in the left eye. And as you can see, this is the fundus photo of both eyes. You can see there is subretinal fluid at the macular area on both eyes. And this is the OCT of this patient. You can see here, there is subretinal hyperreflectivity in the right eye, but also here there is subretinal, there is hyperreflectivity, but not in the subretinal space. And in the left eye, it's more clear. There is subretinal hyperreflectivity, which indicates the subretinal fluid that we saw in the fundus, but also there is subretinal hyperreflectivity, but it seems in the outer nuclear layer, not in the subretinal space. This is what we call it bacillary layer detachment. And this is characteristic OCT sign for some diseases. And the other name of this is the photoreceptor delamination. This is one article. They revise the literature in this bacillary layer detachment, and they propose theory behind this layer of detachment. And again, the bacillary layer detachment is a fluid accumulate at the level of the photoreceptor inner segment myoid. And the theory of this article behind this bacillary layer detachment, it's proposed that the bacillary detachment occur when outwardly directed force promoting attachment of photoreceptor outer segment to the RPE exceed the tensile strength of the photoreceptor inner segment myoid, so that the fluid will accumulate in the myoid space between the inner segment and outer segment in the outer nuclear layer. And this is one photo from a Japanese article. It shows that this is now the subretinal fluid, and as you can see here in the photo. But here, the cystoid space, it's between the inner segment and the outer inner segment and the outer segment. So this detachment happen in the outer nuclear layer. It doesn't happen in the subretinal layer. So this is another article by Maria et al., published in Ophthalmology Retina 2019. They collect all cases presented with bacillary layer detachment, and it can present in patients with PKH, and also can present in patients with toxoretinochoroiditis and posterior scleritis, in patients with CSR patients, and also in patients with retinal toxicity, and patients with choroidal osteoma with CMPM, and some choroidal metastasis disease from lung or from breast. So you have to know this bacillary layer detachment, and you have to know the differential diagnosis behind this detachment. This is the case number 5. This is 5-year-old boy, history of trauma by plastic object 1 week ago. The visual acuity in the right eye is 20/30, and the left eye is 20/20. And you can see that this is the fundus photo with normal disc, and there is abnormal fovea in the right eye, but the macula is normal in the left eye. And this is the OCT of this patient. You can see here there is a normal macular thickness, normal foveal contour. But if you focus here, there is this vertical hyperreflective line at the foveal area. And this vertical hyperreflective line, we call it hyperreflective stress line, or the other name is the foveal crack sign. And this might indicate future full thickness macular hole. And we will go through it in the next slides. This is one article discussed about this hyperreflective stress line in macular hole. In this article, they discussed the prevalence of the central hyperreflective line in eyes with full thickness macular hole. And they noticed that the presence of central vertical hyperreflective line preceding full thickness macular hole and after resolution of full thickness macular hole post BBV, it's approximately 1/2 of the patients. And they conclude that this vertical hyperreflective line might represent an early spectral domain OCT marker for the development of full thickness macular hole. So, and this could be a sign of central foveal dehiscent owing disruption of molar cell cones. And this is another study titled Foveal crack sign and OCT sign preceding macular hole after vitrectomy for RRD patients. And this study, they describe an OCT sign preceding full thickness macular hole formation after BBV for RRD patients. So they had 10 eyes who had secondary macular hole after BBV for RRD. And these 10 eyes, before macular hole formation, all eyes had a foveal crack sign on OCT. And also among 518 eyes that underwent BBV for RRD, but didn't have full thickness macular hole after RRD, foveal crack sign was found only in 3 eyes. And this is another study titled Foveal crack sign as a predictive biomarker for development of macular hole in fellow eyes of patients with full thickness macular hole. And they conclude that fellow eye of patients with full thickness macular hole with foveal crack sign at a very high risk, 77% of full thickness macular hole development, as long as the posterior vitreous adhesion is present. So if you have patient post-trauma, post-BBV, or the other eye has a macular hole, and you have this vertical hyperreflective line, you have to discuss about the patient that the risk of developing full thickness macular hole is higher. So you need to consult the patient. This is case number 6. It's 28-year-old with a male with history of ulcer and seizure, and he also has a rash on the genitalia area, and his visual acuity is 20/80 in both eyes. This is his fundus photo on both eyes, and you can see clear media with slightly hyperemic, mildly hyperemic disc and flat retina. There is no abnormality can be seen. This is the photo fundus autofluorescence, and you can see there is in both eyes there's a ring of hyper autofluorescent in both eyes, and this is his OCT in both eyes. You can see in both eyes there is a cystoid edema, and if you look carefully at the outer nuclear layer at the ellipsoid zone, it is almost disrupted from all the macular area, from the right eye and the left eye also. And you can see this here, the external limiting membrane is intact. And also here, you can see there is a hyperreflectivity over the retinal pigment epithelium. All this intact external limiting membrane and ellipsoid zone disruption or outer nuclear layer disruption and nodular hyperreflectivity over the RPE with the fundus autofluorescent will give you the diagnosis of acute syphilitic posterior placoid chorioretinitis. And this is a very nice article, put new insight on this disease. And they conclude that the spectral domain OCT is the gold standard for assessment and diagnosis patient with acute syphilitic placoid chorioretinitis. And the clinical hallmarks were intact external limiting membrane and disrupted ellipsoid zone and thicker hyperreflective nodular elevation over the RP. So OCT and fundus autofluorescent can diagnose patients with syphilis in such case if the patient present in acute or subacute stage. And this is a nice article published from article about acute syphilitic posterior placoid chorioretinitis in Saudi patient. In this article, they describe the OCT before the treatment, and you can see the exterior limiting membrane is intact, the ellipsoid zone is disrupted, and there is nodular hyperreflectivity over the AB. And after the treatment, after 3 weeks, you can see the ellipsoid zone is completely healed. And this is one of the signs of patient with syphilis. After treatment, usually this ellipsoid zone is healed. So you need to know these signs to diagnose patient with the syphilis. And also autofluorescence can help in such case. Before we go to the next 2 cases, this is a slide about the anatomy of the retinal blood circulation. You can see this is the retinal layers from the nerve fiber layer to the outer nuclear layer. From the nerve fiber layer to the inner nuclear layer, this is the inner nuclear layers. And from the outer plexiform layer and the outer nuclear layer, this is the outer nuclear layer. And the retinal circulation is supplied by superficial and deep capillary plexus. The superficial capillary plexus will supply the nerve fiber layer and ganglion cell layer, and the deep retinal circulation will supply the inner plexiform layer and the inner nuclear layer, and the choroidal circulation will supply the rest. This is the case now, 54-year-old male, known case of diabetes and hypertension, complaining of a sudden drop in vision on the right eye for 1 day. The visual acuity in the right eye is 20/100 and 20/20 on the left eye. And this is his fundus photo in the right eye. You can see there is a patch of whitening involving the macular area extending anteriorly, and the left eye is normal. And this is the fluorescein angiography. This is at 13 seconds. You can see the arteries are filled, but there is incomplete filling of this artery here. And this is after 16 seconds. You can see still this artery not filled yet. And this is the OCT of the same patient, but different cuts. If you look here in this OCT, you can see there is hyperreflectivity extending from the nerve fiber layer to the inner nuclear layer. But if you go here, you can see this hyperreflectivity at different cut at the level of the inner plexiform layer and the inner nuclear layer only. The nerve fiber layer and ganglion layer seems intact. So in the upper photo, this hyperreflective band that involves the inner retina that represent the branch retinal artery occlusion. But here in the lower photo, this hyperreflective band at the level of the inner nuclear layer representing what we call it paracentral acute middle maculopathy, which is descriptive term that we will discuss in the next slides. So this patient has a macular branch retinal artery occlusion combined with paracentral acute middle maculopathy. Now we will talk about this paracentral acute middle maculopathy. And this very nice article reviewing the literature of this disease. In this article, they say that this BAM is this hyperreflective band-like lesion at the level of the inner nuclear layer on spectral domain OCT. And it's likely represent localized ischemia of the intermediate and deep capillary plexus. And it is a descriptive term. It is not disease process itself. So it's not a diagnosis, it's just an OCT term that will help us to know the other diagnosis. So over time, this hyperreflective band that we saw in the slide will evolve into atrophy with attenuation of the inner nuclear layer with persistent scotoma. And initially, this BAM was described in isolation, but with time, it has been observed in conjunction with other retinal vascular and systemic disease. And this is the differential of paracentral acute middle maculopathy. It can be primary, which is idiopathic, which is rare, and can be secondary, which is more common. And secondary can be with local retinal vascular disease and can be extrinsic. And the retinal vascular disease can present with BAM, include CRVO or BRVO or artery occlusion or diabetic retinopathy or sickle cell retinopathy. And it can be extrinsic, like some medication and some viral entity can cause this paracentral acute middle maculopathy. This one study, they describe the spectrum of superficial and deep capillary ischemia in patients with the retinal artery occlusion, similar to our patient. In this study, they describe the spectrum of ischemia as identified by OCT that occur in retinal artery occlusive disease. The spectral domain OCT imaging in their study revealed a combination of superficial or deep capillary ischemia or BAM, and they found this combination of ischemia can present in the same patient in most of their study. And they conclude that OCT imaging may be capable of detecting patients with paracentral acute maculopathy in cases where the fluorescein angiography is normal without any evidence of non-perfusion. And also OCT is a sensitive tool for evaluating patients with retinal artery occlusive disease and characterizing the nature and extent of macular ischemia. You might have patients with paracentral acute maculopathy and fluorescein angiography is normal, but with time, this patient will develop a full picture of retinal artery occlusion. So OCT can be a very good tool to screen a patient with vascular disease. And this study, they put this photo, and you can see this is the patient with the retinal artery occlusion, the same patient. And this is an acute phase, and this is a chronic phase. And you can have this patient in one cut, he had cotton wool spot, which represents the superficial capillary ischemia clinically. And on OCT, you can see the hyperreflectivity at the level of nerve fiber layer and ganglion cell layer. And at the chronic stage, you can see that there is thinning of these two layers. And in patients with full picture of branch retinal artery occlusion, the ischemia will involve the superficial capillary plexus and deep capillary plexus. So the hyperreflectivity will start from the nerve fiber layer to the inner nuclear layer at this photo. And with chronic stage, you can see the thinning will involve all the four layers. But patients with paracentral acute middle maculopathy with deep capillary ischemia, the hyperreflectivity will involve only the intermediate and deep capillary plexus. So the hyperreflective band will be the inner nuclear layer and inner plexiform layer. And with time, you can see there is thinning at the level of these two layers. So you need to know this know this descriptive term, and you know this OCT can be a good screening tool to screen patients with vascular disease. This is case number 8, which is 26 years old male presented to us with history of compressive chest trauma. His visual acuity in the right eye 2160 and in the left eye 2020. And you can see this is the fundus photo of both eyes. You can see the right eye there is abnormal macular reflex, but in the left eye it seems normal. And you can see this is the OCT, but different cuts of the right eye. You can see here there is hyperreflectivity at the level of the outer nuclear layer and outer plexiform layer. And compared with the previous patient, the hyperreflectivity was on the inner nuclear layer, but this patient has hyperreflectivity at the outer nuclear layer. And this is the another cut of the same patient. You can see clearly here is the hyperreflectivity at the level of the outer nuclear layer and outer plexiform layer. So this patient has a hyperreflective band at the level of outer nuclear layer, and this patient has what we call it acute macular neuroretinopathy. And this article discuss the literature about this diagnosis. So acute macular neuroretinopathy, it's usually these patients presented with acute symptomatic photopsia and paracentral scotoma associated with mild loss of vision, and usually more common in women, in more than 80%. And the mean age is around 30 years old, and usually represented on exam by dark reddish brown wedge shape, non-elevated macular region. And usually in OCT, they will have hyperreflective band lesion at the level of the outer nuclear layer and outer plexiform layer, representing focal ischemia at the level of deep retinal capillary plexus, not the intermediate. So in 1/3 of patients with acute macular neuroretinopathy, it appears hyperreflective with well-demarcated margin in patients with using a near infrared image. So also you can, if you go back, these patients can be also diagnosed, but it depends on the MFAS image that it come with the OCT. So you have to check the MFAS image so that it will represent the focal ischemia also. So fluorescein and ICG in these patients will not help a lot. And also patients with acute macular retinopathy, with time they will have thinning in the outer nuclear layer and outer plexiform layer. This is demographic data of these patients. It usually these patients presented more than 73% with scotoma, and bilateral more than 54%. And the risk factor for these patients is more than around 50% with infection and fever, and also kind of presented with trauma, especially non-ocular trauma, like our patient who had compressive chest trauma. So this is OCT image, showed the evolution of this of one of the patients. You can see at initial that there is hyperreflective band at the level of the outer plexiform layer and outer nuclear layer, and you can see after 1 week here the hyperreflectivity decrease, and after 4 weeks you can see there is no more hyperreflectivity, but there is thinning at the level of the outer nuclear layer. And they in their study they classified patients with hyperreflectivity on the OCT into 2 types. The first type, which represent paracentral acute middle maculopathy, and the hyperreflectivity usually at the level of the middle layer, and the type 2, which represent the patient with acute macular neuropathy, and the hyperreflectivity usually deep to the outer plexiform layer. And this is another patient, but present late. You can see there is no hyperreflectivity, but there is thinning at the level of the outer nuclear and outer plexiform layer. So everyone needs to know the paracentral acute middle maculopathy and AMN, and to know the difference between them. And by this, we conclude our 8 cases, and I hope it was beneficial for everyone.
So excellent review of all these topics. So I have a few comments. Hamid, you allow me to about that. First of all, I want to thank you for the nice presentation. You give very nice tips about which is the feature we have in the OCT here. And honestly, seeing by your last 2 cases, I think that the OCT angiography probably, in my humble opinion, could be the way of the future to assess the macular vascular lesions, because the problem is when the patients come lately to the hospital to be evaluated here for the visual acuity loss, sometimes we miss some of the features we see in the OCT here. So probably if you can access OCT angiography from the emergency room, that could be helpful, for instance, to classify on a good way the patients, and maybe they can also give it a better prognosis, a better assessment for the patient. What do you feel about that?
Yeah, OCTA will help a lot, but and I agree with you, and we will show you where is the exact ischemia. But I know OCT angiography to present only maybe here in Kekish and the university. So that's why I bring in this presentation that only OCT. So because I know OCT present in all centers, but of course OCT angiography is very helpful in these cases.
Okay, there is another comment I have it here, because this is a topic I really love about that. And when you show this vertical hyperreflective line, like they call it a foveal crack, you present it in patients with a retinal detachment, you present a patient with macular hole, and my humble opinion, you present a paper. They show you only 3 cases, but you know, there is a study very interesting they do with OCT intraoperative OCT that demonstrate that the patient will have rheumatoid retinal detachment when you put perfluorocarbon over the macula to flatten the retina. There is a lot of cases they can have a macular hole. You induce a macular hole, okay, during the surgery here. So this macular hole, after the gas reabsorption of everything, is closed already. But you see these crack lines in the patients. We probably wrongly think that the probably was part of the healing of the photoreceptors at the macular area, especially in this case with macula off retinal detachment. So maybe it could be one theory, the what you propose here, but I think it's more, in my humble opinion, a more generalized process of healing of the retina here. Because you can see also this, I have seen these hyperreflected lines also in patients with acute macular bleeding, for instance, for leukemia or for maculopathy here. And they present exactly the same hyperreflective line at the level of the fovea here. So maybe it's my humble opinion that maybe it will be a feature, but could be found in different pathology. How do you feel about that?
I agree with you. I'm not aware exactly about that during intraoperative there is this hyperreflective line, but because one of the study I presented that it showed that even patient with who had RD and did not develop macular hole after the foveal crack sign, it's around 518 patients. The foveal crack sign was present only in 3 patients, which indicate this hyperreflective line is more specific and more sensitive tool for developing of macular hole future. But I'm not aware exactly for what about your comments.
Yeah, really interesting. Also, I saw Dr. Hassan Al-Dibi have raised the hand. So, Hassan, the floor is yours.
Assalamu alaikum. Great presentation, Dr. Hamad. It's really, I learned a lot from it myself. Talking about OCT and update for a long time, more than 5 years, we didn't have any grand round talking about OCT in depth and, I know that updated about the new findings in the, new disease, because in the previous era, we are having learning curve about, what are the behavior of the disease in the OCT. But I think so nowadays we have the, the capability to have the multimodals that integrating OCT plus, OCT angio plus infas, 3Ds as well in the same times, couple it together and have the characteristic of the disease. There is certain disease might having their own pathognomonic, points in the disease, like, acute macular neuropathies, which is really one of the things that nowadays we have to, as with the parafoveals. This is, it's not just only specific, just for certain disease, but having differential diagnosis. So looking back to what we have, this is how to having the ability to diagnose disease. But what about the monitoring the disease, Dr. Hamad?
Yes, you are talking about cases of uveitis or?
Both.
Yeah, I showed one of the cases that patient with solar maculopathy with focal ellipsoid loss and the progression of this focal ellipsoid loss over time. And you can see this ellipsoid loss is healed with time, and after 6 months, you can see it's almost healed, and after 1 year, it's completely healed. So OCT also can be helpful in following these patients with focal ellipsoid loss.
Maybe I missed this part because I get just connected. It's great, and really, congratulations for this, collecting cases together in that way and present in a nice way, attractive. Thank you,
Dr.
There is a question also in the chat from Dr. Muhammad Al-Khalifa. He's asking you if you do you encounter focal ellipsoid loss in macular 2 patients frequently?
Personally, I did not encounter, but there is one study they discuss about macular findings, and none of them was focal ellipsoid loss. And the most characteristic finding was multiple cysts in different layer with the absence of reflective technique. But I was not aware of if focal ellipsoid loss is one of the characteristic sign of macular. But I think it can present.
So excellent. There is any more questions to assess to Dr. Hamad Al-Subaie?
السلام عليكم دكتور حمد.
عليكم السلام ورحمة الله.
أيمن الغامدي.
حياك.
Thank you so much for this review. I just want to ask you about the paracentral and the differentiator between the acute. Other than the OCT finding, can we differentiate symptomatically the patient or regarding the fundus exam?
No. If you have patient with only BAM and patient with AMN, you cannot, because these patients usually present with the same scotoma and photopsia, both patients. But there is no specific symptoms that you can guide you to one disease. But by history, it's very difficult. So you need to check OCT, and if you have OCT-A, it will be the best. But by history alone, no.
Thank you so much, Doctor.
Welcome.
Any other question? So you allow me one last question, because I will go further away. So you present a differentiation between the lamellar macular hole, from the tractional to more degenerative models of disease. But you know, lamellar macular hole can be caused by different diseases. Can be, for instance, occur with a vitreomacular traction, can also be the final stage of chronic macular edema. And the problem is, in my humble opinion, problem with the macular hole is the one who can improve the visual acuity, which is the tractional one. Usually they have very good visual acuity. And the ones who have bad visual acuity, this degenerative type that usually they don't improve at the surgery here. So how do you really assess these patients regarding which is the prognosis, thinking that this patient with the tractional, lamellar macular hole, if you are careful, you can be able to succeed. But if you are not careful, you can create a macular hole, you could drop the visual acuity for the patient. So sometimes the patient are not happy with the final intervention about that. So how do you assess these patients?
I agree with you. That's why I brought this case so everybody will know the difference between them. So patients with tractional lamellar hole, usually the visual outcome is better compared with patients with degeneration and retinal proliferation. So usually surgery is indicated for patients with retinal proliferation or the degenerative type if the patient is worsening and progressive with time, and there is ellipsoid zone disruption in different visits. At that time, we can consider surgery. If the patient is stable, and because there is one study, they discuss about the progression of this retinal proliferation with time. They found only 5 of them, they progressed with time. And the other 95%, it will be the same. So we should not be in a hurry to push the patient for surgery. We should wait until except if the patient has a progressive ellipsoid zone disruption. Because as you said, as I said, the aim of the surgery not to gain vision. The aim of surgery to prevent progression, in opposite to the tractional type. And also, as you said, there is a risk of full thickness macular hole because the removing of this retinal proliferation is very difficult. So you have to weigh the risk and benefit, and to check which patient is progressing before you decide to take the patient to surgery.
So I totally agree with you, Hamad. And if there is no more questions, Marwan Abu Hamud has a question. So go ahead.
Assalamu alaikum. Thank you very much for this excellently well presented grand round. Regarding the question about how can they see clinically PAM or AMN, the PAM usually can be seen if you are lucky by can be witnessed or noticed by seeing a grayish or some whitish discoloration, which is exactly as the name implies, parafoveal. And if you are lucky enough, you may, because it's a microvascular insult, as you know, you may see an impulse if you are lucky. But this is, as you said, this is not always the case. And as you also mentioned, clinically, there is no way to differentiate between with absolute sureness between PAM and AMN. Thank you.
Thank you, Dr. Marwan.
Is any more question in the audience? So with that, we conclude the session, and I think I will be very helpful and informative to anyone. I see the reaction of the chat, so people are really happy about that, and I'm more than happy, and I will congratulate you for your nice presentation. It was very helpful, very well designed, and also the images was wonderful. So thank you very much for your presentation.
Thank you, Dr. Robbie. Thank you all.
Thank you. Goodbye.